Good morning, everyone. Thank you for being with us for the second roundtable of the Scientific Day of MDM. Thank you so much for joining us online as well. I was told that there are around 100 people online, which is amazing, so thank you. I am Pauline Bignon. I am the Empowerment and Community Health Referent at MDM, and I'm delighted to moderate this roundtable entitled Empowering People and Challenges. So we have 3 guest speakers, 2 here with us in the room and 1 online in Mayotte. I'm going to start by introducing them. So online we have Charlotte de Thoury, who's going to start. She's a project manager for health mediation in Mayotte. And she's going to talk about a mapping program. Hi, Charlotte. I don't know if you can hear us. You can, amazing. So a participatory mapping program that has been carried out with the population of a shanty town. So it led to different collective initiatives. I'm not going to tell you more about this because she will be speaking about this in details. We also have Emilie Labeyrie. She is a clinical psychologist in the laboratory of Bignon, and she's working on an intervention study evaluating the impact of brief psychotherapy using narrative exposure therapy on reducing symptoms of post-traumatic stress disorder in refugee and asylum-seeking women, together with the Thibaud program in Marseille. And we also have Thibaud with us. She's going to talk about the collective Stop au cancer de nos enfants that she co-founded. The goal of this collective is to better understand the high prevalence of pediatric cancer in the south of the city of Nantes back in 2015. And she's going also to talk about the institute that she co-founded, the Institute for Research and Prevention on Mental Health.
Et tout à fait, on a la chance d'avoir.
And we also have 2 guest speakers from the Institut Martin Chanteau in the public, in the audience. And so do not hesitate to ask questions. Do not hesitate to go to her during the breaks, during lunch as well, to talk about the topic. All right. The working in pairs. So before giving the floor to our guest speakers, I wanted to tell you more about the reasons why we've decided to talk about the specific topic. So for us, and for the rest of the organizations as well, the humanitarian field, it's been a few years now that we are focusing on the question of the participation of the people concerned, make sure that they participate in our actions, in our programs. It's also a quality criteria, per se. It's at the heart of our organizational program. So it's a true political commitment. Well, not for ethical reasons, not for moral reasons, at least not for that only, but for practical reasons as well, and for operational reasons too. Because when the people concerned are associated to our actions, to our programs, then we have more probabilities of, being more efficient and targeting the right people. It's a good reminder. And because it can also strengthen our acceptability on different territories of interventions. It's quite practical here. And our actions are more durable in the end. When it comes to research, it is extremely interesting because the participation of people concerned invites us to, change our mindset, to switch paradigms. Because we have people that are vulnerable, that are living in precariousness, that are going to become not the topic of our research, but people that will be the first players of those research programs. They have resources that we don't. Scientists do not necessarily have those tools as well, those resources, and it changes everything, basically. So we are very lucky today to have 3 presentations that are going to be very different. They rely on different types of objectives, of types of methodologies, but thanks to them, we'll be able to understand what are the challenges, the difficulties, and this way we'll be able to ask ourselves practical questions around participatory research. So we're going to start by giving the floor to Charlotte from Mayotte, and she's going to talk to us about the participatory mapping program she's running there. Hi, everyone. I'm going to check whether I can share my screen with you or not. Can you see my slides? Yes, we do. Go ahead. Amazing, thank you. Hi, everyone. I am a project manager in Mayotte for MDM. And today I'm going to talk about 2 projects that were carried out respectively in 2022 and 2023. So it's a participatory mapping project that led to 2 different projects to create a dynamic of community health services in 2 shanty towns of Mayotte. So I'm going to go back to the context, and I'm going to talk to you about the program that we created in collaboration with the CART ONG. Then I'm going to talk about the support given to community projects, and I'm going to talk about the mobilization of our stakeholders. So to go back to Mayotte first, so it's an overseas department. So it's the case since 2011. So it's located in the Comoros Islands. So it's a very young territory because half the population is under 18, and we have a natality rate that is above the one that we have here in the metropolis. It was the case in 2019, at least. It's also a very precarious territory because 4 houses out of 10 are made of sheet metal. 77% of the population lives under the threshold of poverty, and 6% of the population do not have access to water, and 12% of them are using chargeable drinking water stations to get access to drinking water. We also have undersized services. We have 3.5 less doctors than in France. So we're talking here about GPs and specialists combined. And we know that having access to healthcare is a derogation-based system. So it means that you do not have access to SMA. There is no on-call services. So it means that people, undocumented people, have to pay for medical care. People also can be checked, so we can ask for their IDs, especially around medical centers. So the security policy is in favor of, giving up on care in the first place. And we know that we have a lot of operations, expulsion and destruction of shanty towns going on there. So within that context, so we know that MDM has been present there since 2009. In 2021-2022, we decided to reorientate the program of MDM. So we had a mental health program, and we decided to switch to a mobile mediation program in Zomoni and Longoni. So this is a program we're going to focus on today. It's in red on the map. So the participatory mapping program was launched in 2021. And so it contributes to the diagnosis of new intervention districts for MDM. It's a methodology that relies upon the participation of the citizens, and it's been created with Carte ONG. So we tend to focus on the prevention. Here we're going to go back to that program of mapping to better support community projects and to make sure that we have a strong transition towards the new mediation program. So it's the moderator that is going to support inhabitants to better implement projects in each of those districts and neighborhoods. So first of all, I'm going to focus on our collaboration with the Carte ONG. So it started in 2021, and at the time, the teams from MDM could not really objectify or at least understand what was the best territory to work in, and we didn't have a lot of data on informal neighborhoods. So nothing when it comes to the house, the different pathways, etc. So Carte ONG is an NGO specialized in mapping. It's been supporting different types of NGOs for 15 years. The goal is to use mapping data for different types of projects. As part of this project, Carte ONG has been supporting MDM in creating participatory maps and in creating maps. So thanks to that project, we can meet different challenges. So we can, for example, mobilize communities that are sometimes very far away from decision-making processes. We can also value their practices, their know-how, and how they live on a daily basis in their neighborhoods. And we also give them power. They can produce information. So it's a way for us to compensate for the lack of information, to create geographical data, to have a better perception of the full territory. So we can then implement more adapted interventions. And the third goal is to facilitate collaboration and the sharing of information in between local players, elected officials, NGOs to better understand the projects that are currently being implemented. So we started with an awareness-raising phase. So for the MDM teams and for the inhabitants, so we wanted to tell them more about participatory mapping. Here, the key stakeholders are community volunteers working with MDM, peer volunteers. They are the first link between organizations, so MDM, and the population. So the peer volunteers are trained to those participatory workshops. They are going to do rounds in the neighborhoods to tell them more about the arrival of MDM and to talk about the mapping project and the creation of data. They're also going to moderate focus groups to better understand what are the needs of the inhabitants. Then we have the second phase, which is revolving around collecting data. For data collection, we've used an app, which is called Osmond. It's a free app that you can easily download. It's very easy to use. So you can, for example, pin GPS locations. And then there is a mapping software that is going to produce maps based on those pins. So it's the volunteers that collected data, and we also have inhabitants that also guided volunteers to pin the locations that seemed interesting to them, that we really had to make sure appeared on the maps.
Qui ont été récoltés.
So in total, we have four themes that have been chosen and suggested to the inhabitants of the neighborhood. The first one is waste management. Then we have access to water then accessibility to the neighborhood, and then the living environment and all the spaces that we have to protect. So all of the maps were created thanks to OpenStreetMap data and drones as well, because we didn't have enough data, raw data, I mean, on those different neighborhoods. And then all of the pins that were collected enabled us to create maps based on different topics. So we had in total 130 pins in Gimone and 160 in Digonet. So in total, we were able to create 12 maps. So on this one, in Langonnet, we have 2 maps for access to water. So on this one, in the middle, you can see the river. And in green, we can see all the different locations used by the inhabitants to clean the dishes or to clean clothes, for example. So you can see where the river is polluted. We also have a water collection point. That's the biggest one here on the map. So it's a water collection point to drinking water. We also have free access fountains. So it's water coming from the river. You can see them in red. So it's water that is not drinkable. And so it's, for example, private contact points that are connected to the network. We need to pay to get access to those water points. Then we have objectives as well for water access in Langonnet. So we've produced a second map that we can use to create advocacy work. So these are all of the households that do not have effective access to drinking water. It's the perimeter of 200 meters around the fountains to see who are the people that have access to drinking water and those who do not. So 200-meter perimeter is the perimeter is used by Solidarité Internationale, for example, in the north of France. And it also takes into account the drops, for example, the different elevations, and the fact that it's complicated sometimes to carry out barrels of water. So thanks to those maps, we can highlight the needs of the population. So the maps were presented to the players, the stakeholders, working in the districts of those 2 cities. And the goal was first to raise awareness on those 4 topics that I talked about earlier, and also to invite them to participate in the community project supported by MDM. So following this diagnosis, MDM decided to support some inhabitants groups that were mobilized during the project so that we could choose and vote for a local project that could be supported by the inhabitants and supported also by MDM. So in Langonnet, they decided to focus on access to water, and so it's about selling and transporting drinking water. And in Zoumonier, they decided to focus on neighborhood planning. They decided to create a Thoury. It's a kiosk open to everyone, so all inhabitants, can gather there and organize events. So before that, they've decided to organize a carousel workshop facilitated by MDM workers, and so inhabitants got the opportunity to work on their ideas based on 5 feasibility factors. First, the timeline for the project, the level of technicity required, the budget, the network to mobilize, and the number of inhabitants to be involved. And so based on these 5 criteria, we were able then to identify a feasible project. And so MDM and inhabitants were able to choose what project to focus on, because MDM is not specialized in the infrastructures management or the systems for drinking water. So in Langonnet, So the project was about filling in the different barrels thanks to the chargeable drinking water collection points in informal settlements. So in the center of the city. And the goal was to then redistribute water to marginalized neighborhoods by truck. So in the most elevated areas of the neighborhood. In Zoumonier, the Thoury was chosen. Charlotte, I'm sorry to interrupt you, but you have 5 minutes left. Which is a lot, I have to say. So we had literacy courses given in Zoumonier. The goal was to create a place for people to gather because it's an isolated area, and the goal was also to improve the living conditions of the inhabitants. So here we're talking about women that stay at home and
française pour être plus autonome dans.
And the goal was also to enable them to get access to French courses so they could be more autonomous when it comes to the different paperwork they have to fill in. So we were able to mobilize local stakeholders and stakeholders that are more specialized in those kinds of topics. So we had piloting committees that were gathering inhabitants and local organizations. So those committees gather every week. But yet on the 2 graphs, we can see that the participation varies a lot. In blue, you have the participation of inhabitants. We can see that it's quite high when it's about voting for projects and when it's about sharing, some information on the project with local players. But then throughout the project, we can see the participation fluctuates a lot. It can be explained by the context, the security context talked about, by the fact that we have a lot of policemen at the checkpoints. So if you have policemen in the neighborhoods in the morning, people will not come to the foray, will not participate in the workshops organized by MDM, consults, workshops, etc. So it also depends on the weather conditions, if the neighbors are accessible or not, based on what we could see on the maps before. So for local actors, it's true that it's complicated for us to mobilize them, at least for the full duration of the project. In Longoni, we have a strong local stakeholder, and we also have a steering committee that's quite autonomous when it comes to the funding to the CRESP, and when it comes to, implementing the project. And in Longoni, we have also the city policy, which is mobilized, and we also have the Ligue de l'Enseignement, who is also organizing more workshops for parents and women. We have a lot of women mobilized in that type of project. And to finish, focusing now on the mobilization of inhabitants. So we've carried out an evaluation assessment in 2024, 1 year after the project, so in September, and we were able to see that the reference of the projects talked about, the fact that we were able to improve their capacity of action, improved health as well, fewer constraints to get water, and they were able to learn French as well, so they're more autonomous when it comes to institutional proceedings. They are also more able to help their children, and we were able also to empower them more individually and collectively. They have a higher self-esteem because they can now speak in public. They can debate with other inhabitants, and they can also now organize discussion meetings that lead to a concrete improvement of the conditions in the neighborhoods. So the project is now over. It's been transferred to other players, other stakeholders, and the goal was to initiate community projects that could then be supported by other stakeholders holders to make sure that they are durable in the long term. Advocacy is extremely important as well because those actions aim at giving visibility to health projects and to make sure that then the authorities focus on those topics. So we're talking about drinking water access in Longoni and literacy, thanks to education actors from the public sector in Zomoni. Thank you so much for your attention. Thank you so much, Charlotte, for this presentation. Very rich presentation. But I think that there are things that we can take away from that. Very strong elements. This mapping tool, this participatory mapping tool, that is a real diagnosis tool, in fact. We can mobilize people through that. We can mobilize stakeholders. People concerned. Also, we've seen that the participation fluctuated, but we have institutional partners, organizations, and that's the approach that we have when it comes to promoting health. This is what we promote at MDM. This is how we should create programs, and that's a good example of that. Of course, some obstacles remain. You've described them all. The security context, for example, that can hamper people's participation, but I think it's extremely interesting.
Et de leur accompagnement.
You've talked about the peer volunteers. You've talked about their role in the neighborhoods. And I'm now creating a link with the next presentation for peer volunteers especially. Emilie, Labeyrie, you're not necessarily going to talk about peer volunteers. You're going to talk about mediation rather. You're going to talk about qualitative research with the photo voice, quantitative research as well, and the role of mediation. And I think there is a strong link in between your two presentations. I'm not going to enter the details because I'll let you talk about your project and I'll let you join the stage.
Bonjour à tous. Merci de m'accueillir.
Hi everyone, thank you so much for welcoming me here today. Sorry, I'm just waiting for my presentation to be displayed. All right, so my name is Emilie Labeyrie. I worked in Marseille, as you were told, and so I'm going to tell you about the participation of people. So here I'm going to tell you a bit more about being a co-researcher, and so to do research with people that are being welcomed, and also we'll tell you a bit more about mediation and about being a net therapist. So I will be using the NET acronym all along my presentation. NET meaning narrative exposure therapy. So I want to tell you a bit more about this Indian program. So this is a program that has been created by 4 women that are exiled. There is a teacher of French as a foreign language, a psychologist, a legal worker. And this is a project that comes from a Syrian asylum seeker, and after she met a legal worker to actually lodge her application, they work with women and people from the LGBTQIA+ community because they saw how hard it was for this audience to get access to housing and to just be supported in the administration sector.
Sur la nécessité d'une politique de prévention.
So they work a lot on prevention, and it's community-based as well. So we're trying to adapt it to the audience, especially the audience that is concerned by sexual health and PTSD. So what do we do exactly within that program? Well, here we do a workshop. So it's a collective information workshop. So we do a legal consultation. We also help people individually, whether they have a medical issue or just a somatic issue. We do a lot of different workshops here. And so the idea is to use people's experience of these workers to keep on moving forward. And so here, for example, they are refugees, they're exiled, and they went through the exact same stages, the exact same step when it comes to red tape, when it comes to all of the experiences that they had to go through as well. So this is, a safe place for these people. We also have a lot of different partnerships. So we've developed partnerships, especially in the past 12 months. So this is pretty much the presentation of that program, of that association. And so, talking about migration, especially after the civil war in Syria, we know that the Middle East has been going through some turmoil since 2011. A lot of things have changed. Many different factors are coming into play here. It's not all about Syria, actually, but we know that there is a huge public health issue as people do not have access to care, and it's really important to implement programs and structures to welcome these vulnerable population as much as possible. And so in the scientific literature, it says that migration is actually a risk factor for psychosocial issue, for mental health. So if you already have a pre-existing condition, for example, this can be exacerbated because of migration, because of being displaced, and because you're confronted to new living conditions. So here this is pre, during, and post migration. Community health is the best approach that we can get in terms of care because we're able to take into consideration the specificities of the population that we care for. We try and foster their participation, their contribution, especially when it comes to mental health. We also no longer have, or at least have a reduction of the linguistic and social barriers that we might encounter. We favor social inclusion as well. We are going to recognize people's skills and knowledge, so those that they already have in the territory. And we also develop empowerment. So we try and empower people for them to be able to take charge of their own health and their mental health as well. So then when it comes to the first part, so it's all about the collaborative or participative research. So this is what we call a photo voice. So the photo voice is the idea of this project is to have people participate in the research, so to have them as co-authors of that, co-researchers, if you will. So we take photos and we try and understand a bit better the community, to understand the concerns of the community as well. So that's basically the interest of the research, but to try and establish a diagnosis of the community so that we can know more about their skills, that we know more about their knowledge, and we can participate in implementing solutions so that we can foster social change. So this is something that we've done over a few sessions. We had a photographer that came over to give some classes as well. There was also an anthropologist that is part of my research team. And the objective here was really to try and reflect and mirror the concerns and the worries of that community and the difficulties that they're going through as well, very simply. And so we just wanted to open a dialogue so that we could also open it to the critiques. We wanted to influence political decisions as well, because, this could be a flyer, this could be about writing articles, for example. And at the individual level, well, of course, there are some benefits of that photo voice, because women can finally just take the floor. They can get their voice heard. They can share their experience. They can identify their specific needs. And we really try and be strength-oriented. We don't want to be results-oriented. So this is what we are trying to develop real processes all together, and processes that can just give us some new perspective. So here you have a few photos of the workshops that we've done, photos that were taken. So we've tried to verbalize this with verbatim as well. We talked about fraternity. We talked about the welcoming of refugees. And the idea was, how does Sindian support you in your daily life? So this was for the participation regarding the Sindian program. And then the second point I wanted to tell you more about today was about a quantitative study that was done by the research lab of the ISPAM, so in Marseille. And so here this is about a new tool when it comes to psychotrauma. So the goal of that research is to show how the net therapy, the narrative exposure therapy, how useful it is within a community. So here, for example, you have one branch of research in which we only had people that were benefiting from the Sindian program, so with all of the workshops that we were organizing, and there were another part of these people that were also benefiting from therapy with net therapists, and then we've assessed the results over 6 months. So in France, at the moment, the High Authority for Health, when it comes to treating PTSD, they usually suggest therapy. So we do therapy based on trauma. We also do the EMDR treatment as well. And in England, we have the net that is suggested as a preventive or prevention treatment. So this is a new therapy that is emerging in France. So what is the net, the narrative exposure therapy? Well, this is a psychotherapeutic technique that is quite brief. And the idea is to combine the cognitive behavioral therapy and narrative approach. So there's also a political and social aspect to it, that we also want to recognize the prejudice that people are victims of. And so there is a document that is used with the therapist, that can be used in the whole asylum seeking procedure, but also to handle trauma. So this is a psychotherapy in which we create a lifeline, if you will. And so what's interesting when it comes to this net therapy for asylum seekers and refugees, it's a very brief therapy. It's from 4 to 12 sessions, but it can be very useful and very efficient. Just with a 4 session is really accessible as well, because there's no exclusion, no criteria, whether it's social or economical. It can be in a precarious environment, because this is something that was tested in refugee camps, actually. And it can be done by people that are not official carers. So you can just be trained. So you have peers that have the same culture, that have gone through the same difficulties, that can be trained to proceed with narrative exposure therapy on their peers. And usually we focus on one specific trauma, but here with the net therapy, we usually focus on trauma overall. So in terms of research, here are the different scales that we've used, different grids that we've used. And so the mediators were doing the grid scheme by themselves, and then I was intervening later on in the process. So 46 women went through that net therapy. And that's it. I think the question that remains, the remaining question is, when we train people, or at least what I'm interested in when I'm researching, is that I want to know more about how people participate. The mediators, when did they feel legitimate to actually become a net therapist? And I'm also interested in what concerns it raises raises because they benefited from a training. So this is a training that was conducted by Isabelle Duty, who's a doctor. She was also trained. So they went through 4 training sessions with theoretical classes. They also have done some case practices, practical cases, sorry. So we've done that in 4 different training sessions. And so to conclude, the challenges that we're faced with is that we need to think about the deontology. What is the limit of these mediators? Because of course this is still a complex therapy. So how can we try and professionalize that so that we can keep on reinforcing their legitimacy? We also make a difference in between peer workers that usually go through training modules so that they can get inspired as well. It gives them hope. It creates new relationship. People are able to bond. And so here, when it comes to mediators, we're really identifying. It's all about identification and trying to solve conflicts. So they themselves have mental issues, actually, mental health issues. So the idea here is to try and reflect on training. We had, for example, a psychologist that was participating in every single module, so they were supervising. And so we had, we have to think of all of this, all of the different challenges that we're faced with. Food for thought.
Merci beaucoup, Emilie.
Thank you so much, Emilie. You summed things up yourselves, and you've given the highlights of that presentation, so I'm not going to mention those again, I think. But I just wanted to say that this question of professionalizing the mediators that work in a health sector, I think it's something that resonates with us in MDM, not only for mediation in health, but professionalizing people that come from these community, and how can we help them, how can we train them. I think it really resonates with us and with our work.
Voilà, je voudrais le souligner, puis je pense que les collègues viendront sans doute voilà, vous discuter.
And I think our colleagues will probably come to you for further information on that. But it's extremely interesting, especially when we talk about a community approach where people are responsible for their health, they're responsible for their peers, and here in that case with Marie, I think this is exactly the topic that you're going to tell us more about with the collective and the Citizenship Institute that was founded by inhabitants, by families, by the population itself. And I'm going to try not to say too much that I don't want to spoil your presentation, so you have the floor. Well, hi, and thank you, MDM, for inviting me to do this presentation, to present to you the approach that we adopted several years ago now. And so I'm going to wait for my presentation to be displayed. So my name is Marie Thibaud. I created the collective called Stop au cancer de nos enfants. And so now we've created, Stop Our Children's Cancers Collective. And so now we created an institute on mental health. So why did we create this collective? Well, because in 2015, my son he turned out to have cancer. He was 4 years old. So I live near Nantes. I've always lived in the Sainte-Pazanne, and I've never heard about children's cancer. I didn't even know that it existed, or I think it was really marginal. And then I realized that many other children were actually getting cancer, and I was meeting them at the pediatric unit at the hospital. And so I was wondering, is it because I'm a mom who has a son that has cancer that I see cancer children everywhere, or is something happening? And something was actually happening. And so after 2015, meeting all these children that were getting cancer in the same area, I decided to create this collective called Stop au cancer de nos enfants. So this collective was created at the end of February 2019. So we're starting to create a structure. We are creating a website, and then little by little, we got some media coverage, and we've been able to pay for analysis, whether it was in the water environment, the ground, soils, hair, and at some point we start to also have some political support, and we have state representatives that started supporting us and get more media coverage here. We keep on participating to different events. In the past 2 years, actually, were very rich, and this is why we started to create the Civilian Institute for Research in Environmental Health Prevention. So here, those are registers. So this is census, So I invite you to see which department actually have the census and which do not have those. In the Loire-Atlantique department, my department, they do have census for pediatric cancers, but they are not used to do more than just given data. And usually data arrives really late, years late, which means that they're not here to raise the alarm when needed, and they're not also used for mapping. So it's just basic census with data that are very obsolete. When I contacted them in 2016, they didn't start on the data that they had back in 2012. So of course it was impossible for us to know what was happening in our area. So in our area, you can see that there are many different sectors in the south of Nantes. Now you can see that we have all of these children that declared cancer, and we only know that because we know these children, because we met at the pediatric unit. In 2024, we still do not have the data from Santé Publique France or from that census of the Loire-Atlantique department. So before 2015, as you can see, we had no pediatric cancer, and from 2015 it was raising. So it wasn't just in my head, it was a fact. So 2015, we realized that we do have pediatric cancer. End of 2016, I started, doing my research to try and raise the alarm, saying, okay, in between, it's a lot of children having cancer. So in April 2017, I'm able to reach the regional health agency, and they start raising the alarm as well. They are doing their own investigation. So they do what I would call an administrative investigation up until mid-2018. And their conclusion is that we have a cluster of pediatric cancer. So this is on a given time in a given area. So there was a cluster of pediatric cancer. So that was July 2018. There were more children than that, but they've given their conclusion on 6 children, and they indicate that there are 4 different factors that could be environmental risk, which is hydrocarbon, benzene, radon, and pesticides. I mean, of course, if you go on Google and you put pediatric cancer, those are the 4 factors that will come up in the Google results, and end of the investigation. But we're not talking about the causes. Why would these causes be and these risks would be higher in our area? So we have first, more and more children that start to get sick. There are children that die. Thankfully, Alban, my son, was getting better and better, and he's finally in remission in 2019. So this is good news. But other children, including a child that was in my son's class, actually cleared cancer. And here I understood that, I was just, that people were not taking me seriously. I'm not in contact with the regional health agency, and I decided to just create that collective because I want for people to know what's happening. I want to raise the alarm, and this is when Mathilda, who's in the audience, actually joined the collective at the time. And so by putting pressure, we started putting pressure, and so some follow-up committees. We're not giving the opportunity to Santé Publique France to not do anything. We want to put pressure on them. And so what they do is that they do an epidemiologic survey that they send to families, but they don't send it to all of the families, of course, because they want to take all of the children into consideration. They wanted to put some of the children aside. But I'm not going to go too much in detail. So in November 2019, they are able to confirm that there is a pediatric cancer cluster. There is 11 children that they take into consideration when we actually had 17 at the time. And they're also, again, saying that there's no common cause to this, so no research, no investigation is going to be launched, because basically nowadays, if there's not one specific one and only one single root cause of a pediatric cancer, then they cannot move on to the next phase. So there is no environmental study that is being kicked off. Of course, there is not a single cause, because we know that pediatric cancers are not linked to only one environmental factor, but to several of those. So again, the investigation is just shut down at the end of November 2019. We hear in September 2020 that Santé Publique France, SPF, has decided to change the perimeter and the time lapse. And again, of course, there was no longer any children with cancer, though we had 25 children with cancer. They were here, they were existing, but with the data that you use, the figures that you use, you can say anything with data. And so we knew that we could no longer rely on the health authorities. We couldn't rely and trust SPF, and so we started thinking of what we could do all over the territory to try and understand what was happening. This is the sanitary democracy, as I like to call it. This is all about what's implemented by health authorities. We also do a lot with the states. So what we do is that we consider that the methodology that is used is no longer adapted, and that we need to develop further scientific knowledge. We have to do scientific research in between environment and health, and talk about health environment. And environmental health, sorry. So we're talking about different root causes for pediatric cancer. We know that children are the first victims of environmental, or rather the lack of environmental health. So we need to look for what's there. So we want to have more research. We've already done some research actually on many different matrices, for example, that could be taken into consideration, but we want for all of this data to be collected, we want these data to be correlated to one another so that we have real conclusion and we're able to actually keep on moving forward. I mean, if we do research, but if the research is useless, then there's no point in doing it. So we want this research to be used for the government to do something. I also wanted to tell you a bit more about the poly-exposure, which means that when it comes to environmental health, everything revolves around isolated factors. So we are going to work only on heavy metals. We're only going to work on pesticides, or not even pesticides. We're going to take one phytosanitary product, but we're not going to correlate it to another one, and another one, and another one, and so on and so on. In our area, in the south of Nantes, of course, there are pesticides, just like everywhere else in the country. But maybe the difference in this area is that we are on an agricultural land. It's a vertical land. It's a vineyard as well. And, you know, whether you produce wheat or you produce oats or whatever, you don't use the same phytosanitary product. You don't use the same products for vineyards either. And so if we take those products individually, then there's not a problem. But then if we put all of them together, then we have an explosive cocktail. In our area, we also have a lot of different studies that were conducted regarding the electromagnetic fields, for example, and if you add it up to radon, then you just multiply the risk of developing pediatric cancers. So we have studies, but they're too siloed, they're too fragmented. We need to break the silos and try and find the different factors and try to see what are the results when we put them all together. Because as you understood, all of the standards that are implemented, they don't take everything into consideration together. And so we want to go further, and we want to do analysis in wine, in the air, in the water, in hair, in geobiology. So all of the studies that we conducted ourselves. 2 minutes left. Okay, I'm going to try and go a bit faster then. All of these studies as well were individual studies, so we couldn't go further. So the mission of the institute that we created, I mean, we have the status of an association, but we do have objectives. We want to understand what's happening. We want to prioritize scientific studies, and we want for our legislators to have enough data and relevant data so that they can work on improving the environmental and sanitary conditions. We also want to do some prevention and protection actions, and we want to raise awareness when it comes to environmental health. Here, I wanted to tell you a bit more about the governance and the role of each players. Of course, we always have a board. I mean, I'm not going to go on, how a board works, but we also have a scientific committee as well. So we have about a dozen of experts working on different sciences, whether they're sociologists or they're toxicologists, whether they work on many different topics, and so they will. The scientific committee, they actually gathered for they actually only gathered 2 times. They're going to gather for the 3rd time very soon, and so they are going to assess everything, and they will be contributing to the different releases. And they will also have a civilians committee in which citizens can actually participate in that. They can participate in that fight. They can contribute to the research. So they can participate to the research, but they can also talk about the research and raise awareness directly in the field. And so here, thanks to the funding of our department, because of course we're all volunteers, so we're all very limited in terms of what we can do, but to try and make up an operational team. With the funding, we've been able to recruit the director of the institute. She's an employee of the institute nowadays. When it comes to the funding plan, it's just for your information. We have about 100,000 euros nowadays, with a huge contribution from the Loire-Atlantique department. And we are also working towards trying to get some patronage, and we want to be very active. We organize a lot of events so that we can raise money as well, so that we can keep on moving forward. I had so many more things to tell you, but I hope I will have the opportunity to tell you more about later. Thank you so much for your attention.
Merci beaucoup.
Thank you very much. The notion of participatory sciences that you've mentioned, that you talked about, is extremely strong. And I also think that it's a beautiful way for us to conclude on these 3 presentations and to open the Q&A session. Because we put the finger on the fact that there are different players, different stakeholders, and how they all fit within those research actions. And there are different questions in the chat, questions in the room as well, so I'll keep my questions for later. We're going to start with the questions from the audience, and we have 2 questions in the chat, I think. Hi everyone. First of all, I wanted to congratulate you for fighting this battle. It's a very strong initiative. I wanted to know more about the perimeter of your institute. Is that in Nantes only, or are you present in other regions as well? And I have a second question. What's your relationship with the Santé Publique France today?
Les relations avec Santé publique France sont closes depuis septembre 2000.
So our relationships have ended, but within the institute, I haven't detailed it yet. But we were able to invite them permanently, so we have the regional agency for health from the region, and so they put at disposal of the institute all of their data. So it's a big move. We will now be able to collaborate together. And second question, we were supported by the institute, the Eco-Citizen Institute of Fos-sur-Mer for pollutants. The institute was created 12 years ago, and they are, reflecting on the activities of the port in La Fos-sur-Mer, and they are reflecting on pollution that could have an impact on health. So they started from this a few years ago. They supported us, they made progress, and so we drew some inspiration from that. So we started from a health issue, and now we are connecting that to environmental health. And yes, the goal is for this science, this participatory science, this health democracy to be present everywhere in France. You may have heard of it. In Chamonix, we are currently creating an institute in the valley. They are currently hiring their director today, as we speak. There is another institute that was created in L'Aude and in Lyon as well. We are also, identifying the same problems, the lack of action from the state. So the goal is to create an interface in between science, citizens, political officials, and we want to be present on the territory, because when you're present on the territory, you have levels of action, because you know what's going on, so you want things to evolve, and the goal is to create other types of institutes everywhere for all institutes together to share results and to create a strong citizen platform. We're all citizens in the room, whatever our role. So. Hi, I am Danielle Sonnet. I am a nurse at La Goutte d'Or in Paris. I'm a member of MDM as well. And I have a question, well, rather an observation to make. When sharing, skills, based on what we've heard here, on the capacity of action, and what's happening in the public space, in our health centers, we are currently being supported by community centers, and I think that there is an amazing transfer of know-how and knowledge. So my question is the following. What's the difference between mediators, peer volunteers, facilitators? I've heard different types, of descriptions. Does that entail different types of statuses? I don't know if it's too technical for you, but we need to know more about the different roles, that they have and that they play. These are things that I am currently working on, because we have peer workers in mental health. So we have prevention moderators, for example. It's not new, but it's new in psychiatry. It's been created 10 years ago, but in addictology, for example, in the US, in the 1970s, we already had peer volunteers, but in the psychiatric field, it's quite new. For HIV, for addiction in the 1990s, we already had those types of volunteers, peer volunteers. So there are trainings for peer volunteers. And I've tried to think of their mission, their functions, and their feeling of legitimacy as well. how they feel about themselves. It can be, for example, related to our job descriptions. You can be, for example, an administrative agent. I'm coming from the hospital, or depending on, their role, they can have, a degree. It depends, on the role that they play. Nothing has been created yet. So it's a fight that we need to be involved in, because we want people to go backwards. We have people that have taken power, and you can't, oppress people that have been oppressed already. That's why I'm working on this, and for need therapy especially, we're not talking about psychiatrists or nurses. The goal here, the idea, is for everyone to be trained, and it's complicated, when you want to get some funding. Let's not forget Charlotte in Mayotte. If you want to react, do not hesitate to do so, because these are questions that we ask ourselves here at MDM. Charlotte, if you wish to react, please do so. Peer volunteers, for example, who are the peer volunteers for your program? What are the relays that you have in mind for later? For example, do you like to say something about this? Yes, thank you very much for giving me the floor. We are not thinking about this, well, at least not with the same terms. Because we have peer volunteers, community relays, they don't have a professional status. They are not recognized in terms of profession. Something that we have for mediators, for health, because these are new positions, new jobs in Mayotte that are very popular. And I think that we don't always have the same definition of the role, of the job, of the function, nor the same definition for community relays in the districts, in the neighborhoods. So as part of the program, we are working with peer volunteers, community volunteers that are not living in the areas of intervention. They are not experiencing the same conditions, but they can share the same language. So they had the experience of living in precariousness. But we're going to identify community relays that would like to train and that would like to work with afterwards, during the second phase. So we realized that if we wanted to have a pool of community relays, we had to first improve their individual knowledge on health and improve their own individual situation. So there are two levels here. Two different levels for peer volunteers that would like to develop. And the health mediation program aims at promoting knowledge, promoting skills in health, so that we can have community relays that can participate in monitoring processes for outbreaks, for example. But I wanted to add the following. Based on the different organizations that we have on the territory, we don't have the same definition for health mediators, for peer workers. For example, some will share data. For us, it's more about creating individual trainings. We don't have the same tools for prevention as well. And it's something that is developing today because health trainings are now becoming the heart of the work that we do. One question here in the room, and then we're going to take some questions from the chat. I am Alfred Spira. I am a researcher in public health and in epidemiology. I was the first director for health watch. So I was part of the board of administration. I was the director of the board, and I think that your approach is extremely positive, extremely interesting. But you present it as a conflict, you know, a conflict with university research, academic research, and public research. And I don't understand why. There is no reason for that. Because in Santé Publique France, there is a citizen committee. It's been created 12 years ago. The documents from Santé Publique France are public administrative documents that are accessible to everyone. The reality is quite different from the one that you've described. I understand that you have a specific perspective on the outbreak, and it's true that you haven't talked about an outbreak at all in your specific region. But if we have a look at the national perspective, you said that there are only 14 census, but there is a national register for leukemia, for example. This is the most prevalent cancer for children, not only in France, but in all countries around the world. So I'm not going to develop on that because I don't want to speak for too long. You talked about the fact there is no research on cocktail effects, and there are hundreds of publications on that cocktail effect. And we have research, some research that a lot of researchers have participated in, for example, French researchers from Santé Publique France and foreigners as well. There are multidisciplinary approaches. We also have different types of exposures. You're saying that this research does not exist. A research, you know, creating a link between health and the environment. And the first country, you know, to have enshrined in the law the notion of expo zone was France. I'm not going to enter the details here. And I don't understand why you're not working together with what's existing, so, you know, a public research that is transparent, that is opened. Why do you work in a position with us? It's quite extreme. And in the end, it doesn't bring anything positive.
Non, non, non. Merci pour votre question. Je me permets.
Thank you for your question. I understand your approach. I understand what you've said. We were in that dynamic in 2016, 17, 18, 19. And then the facts were there. The human support of Santé Publique France was catastrophic for the families. There were public apologies made by Santé Publique France. Why? Well, because their support was indecent in terms of scientific skills. They also had to make a lot of apologies on the recommendations that they made. And to conclude, they say, okay, there are environmental causes. 90%, you talked about the expo zone. I haven't talked about this. Yes, it's true. 90% of pediatric cancers are related to the environment. Only 5 to 10 are genetically induced. And in our area, all cancers have been related to the expo zone. It's in the report, in the conclusions of Santé Publique France. They say, they've written that they don't have the financial means for the state to give them a specific mission to have a closer look of what's happening on our territory. It's not part of the mission, it's not part of their methodology, so it's been stopped. And so Santé Publique France doesn't have the means, you know, to carry out environmental research for pediatric cancers and the environmental causes. I'm not saying that they're not doing any, you know, any research. They're working with a lot of researchers, a lot of scientists as well. Well, at least all of the scientists that are integrated, the scientific committee of the institute, are researchers. They work with state bodies, and because they are academics, they work in silos and they're limited in their interventions. That's why they wanted to join us, because they wanted to break the silos, to make sure that they could work together hand in hand. And it was not possible because, you know, the researchers come from the INSERM, CNRS. We had some links with them at the time when we were working with the Santé Publique France. That's why they were not able to go further, unfortunately. They can't do more because their methodology did not enable them to go further, and I hope it answers your question. It was very clear. So the idea is not to work in opposition to Santé Publique France. I think they wanted, you know, to be in a position. But we really wanted to collaborate with them because we are experts of our territories. We know our territories by heart, and so relying on citizens that are experts is extremely important, you know, to go further, to promote the health of everyone. So that was the idea of the Institute. We really want to cross everything. Participatory research, science, we want to break the silos, we want to create something new, something different. And I hope that Santé Publique France will go in that direction as well. This is not our institute, you know. If at some point we can, you know, organize things by new ways of functioning, well, we'll do it, you know. That's why it's an open institute. I haven't entered the details of the board, for example, but there are different bodies of the state that are part of the board of directors. We have a permanent, for example, guest, and if Santé Publique France would like to participate, well, please join us. Thank you so much. No questions? All right. There are a lot of questions in the chat. One question and a half maybe, because one is really short. One of them is really, really short. So first, lots of comments, lots of remarks to understand how we can support you. We have a question for you as well, a simple one, on where to find the results of the psychotrauma study. It's ongoing. It's an ongoing process. We're working on that. I'm going to try and choose the right one. Mayotte, maybe? To ask questions to all of our speakers. So, Charlotte, given the political context in Mayotte, how did you take into account the risks posed by those mapping activities? They could be, you know, identified by policemen and authorities. I haven't developed that in the presentation, but if you're interested in that, there are some written reports. It's true that it was a big challenge for the project from the very beginning. It was a fear coming from the inhabitants and MDM. We didn't want to produce a data to then, you know, encourage destruction of the shantytowns and slums. So Carto-NG and MDM and the inhabitants decided for this data not to be open sourced and for those maps not to be shared in open data, as open data, to protect ourselves from that risk. Risk that had been illustrated by an article from Mediapart on the DL platform used by the police, something that we see here as well in our metropolis. In Mayotte, the goal is not to, you know, give more information to the authorities, to the police authorities. So those maps are not accessible to everyone. They are open to, you know, the collectives. They can be shared for, you know, advocacy work with the ARS or other stakeholders that we consider to be safe and secure. Thank you, Charlotte. We're going to stop now because we're running out of time, but it's true that we had a lot of questions in the chat. So thank you for your questions. So I'm told to tell you that lunch will take place in the foyer and we'll start again at 2. And for people online, please try and reconnect at 2, right? 2 p.m. Yes, it's been confirmed, 2 p.m. And do not hesitate to grab some ribbons, for example, to show solidarity to the collective and for people that are concerned by pediatric cancers.